Good afternoon, friends. I'm really thankful to the organizer of UPSI to ask me to share the recent trends in the varicose veins. As you know that varicose veins are very common and almost about 50% of the population, they suffer in their lifetime from the varicose veins. If they're in the initial phase, probably they are not much of the problem. There's only the cosmetic problem is there. But as the disease advances, the most change in the quality of life of these patients comes because of the ulcer formation and the features of the chronic venous insufficiency. Till date, after so many years of the treatment of varicose veins, still we are looking for what is called the holy grail, which means that the treatment of the varicose veins should be quick, it should be painless, it should be suitable for all type of veins, and it should be technically easy without any complications. No scars are left. The patient must make a painless recovery and go to his work as early as possible with a high patient satisfaction and probably without any recurrence or the very low recurrence rate. There are many options which are there for the varicose veins, like you can use the compression stockings, the medical treatment, the lifestyle changes, the various types of surgery are there. But in the recent years, for the last 20 years, we have got a lot of the endovenous treatment for the varicose veins. Initially, there were the thermal treatments and then came the non-thermal treatment. And now even going to the no invasive technique, what is called the high frequency ultrasound. Looking at the compression stocking, you can see few years back, the type of the stockings, the Una boot which was there, and then all these stockings become more and more delicate, more and more patient comfortable, so that the patient can easily use them. And now there are zippers which are there, which can be used for that, because the wear the stocking and unwear the stocking, both are really difficult. And the surgery is lot of surgery treatments are there, though they are not obsolete. They are still in vogue, and many of these things are combined with the various type of the minimal surgical techniques. But the classical one is a tendon bug operation where you do the flush ligation of the veins, and you can look for all these three tributaries which are there, and then you can go for the mini phlebectomies for these patients to take care of the small non-truncal veins. And then sometimes the patient having the venous ulcers, you may require the mesh type of the grafting, or even sometimes the flap repair may be required for these patients. And then you know about the radio frequency ablation, the laser treatment, endovenous treatments which are there. And then came the MOCA. MOCA is the mechanico-chemical ablation, and the glue treatments has come for last about 5 to 10 years. So we have got both thermal type and the non-thermal type, or the tumescent type or the non-tumescent type of the treatment for the varicose veins. And these are the various non-thermal techniques which are there that you can use the patient with a glue treatment. You can use the patient, the mechanico-chemical, where mechanical plus the chemical, the sclerosants are given to damage the endothelium, or you can use the foam sclerotherapy for these patients. So what are the recent changes which have occurred in the treatment of the varicose veins? The most important change which is there in the 2020 is the 2020 CEAP classification, which has got several modifications. And then you can have the cosmetic procedures for the varicose veins, the laser crossectomy, the type of the laser has changed, the type of laser fibers have changed in the recent years. Then we have the microwave and the steam therapy as the thermal treatment, then high intensity focused ultrasound, the HIFU, and a landmark trial in 2018 came for the venous ulcer, what is called the EVRA trial. And then now we require not only the EHIT, endovenous heat-induced thrombosis, but now we also require the EFIT, that is the foam, and EJIT is the glue. And then even the artificial intelligence, which has come in the various ways in the medical field, is also there coming for the anatomical and the pathological changes on MR virography for the varicose veins. So this was a classical CEAP, which was there, the C1 to C6. So what are the changes which has occurred in 2020? Now, from the C2, we have added the recurrent varicose vein. It was not there in the initial classification. Similarly, the recurrent varicose veins for the ulcer, which is there, the C6R has also come. But the most important which has occurred is the C4C. Now, C4C is a new addition in the C4 class. We had only the C4A and C4B, but the corona phlebitica, which was supposed to be of the C1 class, has now come into the C4 class because it has been seen that it's almost about 5.3 times more likely to develop an ulcer. And that is the reason it has jumped from the C1 classification, the 2004 CEAP classification, to 2020 into the C4C classification. And then in the E, we have added the secondary type, which is there, the ESI and ESE, which means whether it is the intravenous variety, means like the DVT, which is there, or it is the extravenous variety, means there is a compression from the outside is there, like the patient having the May-Thurner syndrome or Nutcracker syndrome are included into this group. And then in the anatomical one, what was there in the 2004 that there was numbers were there, but now these numbers have been replaced by the new abbreviations which are there, like the GSV, great saphenous vein, above the knee is called GSV-A, and below the knee is called a GSV-B. So instead of all these numbers which are there, now there are abbreviations for that. And there is no change in the P. So there is a change in the C, E, and A, and no change in the P type of the CEAP classification. So these are the various differences which are there in the C, in the E, and in the A, but no updates on the P. Then in the recent year, the various wavelengths have come for the laser. You know, we initially started with the 870, then we went to 980, and then we went to 1470. And now the recent one is 1940 nanometer, which is there. And the advantage of this 1940, which is there is superior absorption in the blood and the vein wall. So the total dose is reduced and there is less thermal damage. So that is the advantage of 1940. And now the various laser fibers are also changing. And from the bare fibers, it went to the radial fibers, and now it is the corona infinite ring fibers which are there, so that you have got a more uniform distribution of the energy. So that is the advantage of the corona fibers. So these are the recent change which has occurred. And then people always thought that we were stopping this laser 2 centimeter proximal to this saphenofemoral junction. But there was a chance of recurrence because of all those veins which are there, which are draining into the GSV. So people, again, just like we are doing the saphenofemoral junction ligation, people have started doing the laser crossectomy right at this point here. But you have to be very careful, and there are very few centers who are carrying out, and they have to be really expert to carry out. Otherwise, there's a very high chance of having the E hit in these patients. And in the recent years, the steam ablation as a thermal treatment has come, and it is almost equivalent to the RFA and to the laser, with the reduced pain and the greater satisfaction. And similarly, the endovenous microwave has come with a temperature ablation about 90 to 100, and they also have got a similar outcome as that of the EVLA or the RFA. But this is probably one of the most important recent advances which will be coming recently. I'm not sure whether it is available in India or not. It's only available in one center in UK. And this is a high intensity focused ultrasound, which is almost a non-invasive technology. So you are using only the very high focused ultrasound for that purpose to block the saphenofemoral junction. And there are several advantages of that. That definitely there because you are not invasive here, so there is few risk to the patient. Minimal local anesthesia is given at only the site where you are putting the probe there. Otherwise, no other injections like or the tumescent anesthesia which is required. So it's the best treatment for patients who has got a needle phobia. And it can be even used for the venous leg ulcers. It's a daycare procedure. Patient anticoagulant because there's no chance of bleeding is there. It can be used. And you do not require any operation theater. It can be done as an OPD procedure. And because you are not putting anything inside the vein, so there is no chance of foreign body thrombus or the embolism. We have been using for the cosmetic surgery for a very long time that you are injecting the direct the sclerosants inside these small spider veins. But in the recent year from Brazil, this technique which has come, what is called the CLaCS, Cryo-Laser and Cryo-Sclerotherapy. And this is for the C1 disease that you are carrying out these things. And it has got 4 components that you first cool the skin up to -20. There's a cryo cooling is there. And then with the help of the infrared, you do what is called augmented reality so that the veins, they are projected here. So they become projected veins here so that you can easily give the laser and the sclerotherapy. And then you're using the transdermal laser. And this is using ND-YAG laser, which is used 1064. And finally, you can inject the sclerosant like the dextrose solution inside a small vein. But it has been seen in several Indian studies that this CLaCS technique is not having much of the advantage over simply carrying out the sclerotherapy, because as such, the sclerotherapy will be very cheap, while this will be a very costly affair. And finally, a very important trial which has come for the venous ulcer was the EVRA trial, which is from UK, from the Ellen Davis group, where they have studied the 450 patients at 20 centers in UK, published in the New England Journal of Medicine 2018, where they divided their patient, the venous ulcer, into 2 groups, the early intervention group and the deferred intervention group, where either the delayed intervention was carried out or the patients were kept only in the compression therapy. And they found that there's a definite advantage of carrying out the early intervention in all forms: median time to ulcer healing, the rate of ulcer healing, median ulcer free time, which was there during the first year. So in all these, it was found that the improved ulcer healing rate is there, there's a decreased recurrence is there, and there is more ulcer free days are there. So I think that may become a standard of care for the venous ulcer. So we should not only keep your patient only the compression therapy for the venous ulcer, but you should go for a early venous reflux ablation, usually by any endovenous treatment. And then as more and more techniques are coming, more and more terms which are coming, we only heard about the E-HIT. Now the E-FIT is there, where it is because of foam sclerotherapy, or E-ZIT is there, where it's because of glue sclerotherapy. And you know that whenever you're doing the glue injection, we keep at least 5 centimeter proximal to the saphenofemoral junction, because if this glue goes into the deep veins, there is a lot of problem. And finally, as in other medical fields, we are thinking about the artificial intelligence. Similarly, the artificial intelligence is being used by carrying out the MR venography to study the various anatomy and the pathophysiology of the varicose veins. So friends, finally to conclude, what are the various recent changes? That more and more demand for the cosmetic techniques are coming now. And we started with the invasive techniques, we became the minimal invasive, and finally probably it would be no invasive technique for the treatment of the varicose vein. And this trial of the EVRA trial which is there, it is EVRA trial which is there, it's a very important trial where you can say that your varicose ulcer patient will require the early reflux surgery to heal the ulcer early and to keep the ulcer healed for a longer time. Thank you very much. सौम्या, सौम्या, देखो बेटा स्टॉप किए, अब क्या करें? अब कहाँ है? नहीं, कन्वर्ट अभी नहीं हुआ, अभी हमने स्टॉप एंड कर दें इसको।